Hey everyone, this is the EMS Action Items for April of 2021. This is a new attempt at a way to deliver content from the last quality management meetings that we have every month. Hopefully this will engage you guys and create some discussion locally at the station level. So we got a lot of really good feedback from the fields and was asked recently a couple times to add not only the top 5 units for EMS call volume, but the last 10. And I'm glad that you guys like this feedback. And I hope you guys can have some camaraderie talking about this around the station. This is last month's performance snapshot. Overall, we're continuing to do a great job. ROSC rate is higher than our expectations. However, if we can continue to use that rescue pod, making sure that we get that rescue pod on every patient, please ensure to add EMS 17 to all high acuity calls regardless of their location.
The EMS division is aware that wait times at hospitals are longer lately than they normally are. In these instances, please contact EMS 17 if they're not on duty. Contact your battalion chief if it's going to be over a 20-minute wait. For more information in regards to hospital wait times, please refer to IM 27. It has the county definitions for critical capacity and diversion.
So every 3 months, the protocol committee meets and makes changes to the protocol along with Dr. Roach. I understand that those protocols are hard to keep current with. That's why Dr. Roach has made the protocol app that's easily accessible. Please review these dosages and current protocol changes while on these high acuity, low frequency calls. It's extremely important. There has been some question recently about what is necessary to list in the flowchart specifically on a cardiac arrest. The items listed below on this page are some of the things that need to be in the report before it can be closed and reviewed. It's extremely important and legally required that all EHR reports are locked by the end of the shift and uploaded. If you're unable to do that, contact EMS 17 or battalion chief for approval for overtime. Let's talk about the shift report review SOG 128. As you're aware, station captains, you're responsible for self-assigning all the reports completed in EHR for your rescue truck. That must be completed by the end of the shift. On the other hand, if you run a medical call and have to complete an EHR report, you must have that reviewed by the station lieutenant. Please use this opportunity to coach the lieutenants in the review process. So the EMS division is aware that the transfusion whole blood protocol is something that is not in a lot of people's thought. However, take an opportunity to familiarize yourself with this because whole blood is absolutely life-saving. And the quicker we're able to recognize that the patient needs whole blood, the better opportunity we have to make a difference in that patient's life.
It's incredibly important that we're all familiar with our trauma alert criteria. Specifically this month, we're asking you to look at burn trauma alert criteria. We're all most likely familiar with level 1, consisting of second or third degree burns of greater than 15% body surface area. However, we need to review level 2 as well, which includes burns involving the face, eyes, ears, hands, feet, or perineum. That may result in a functional or cosmetic impairment. We're talking about life-changing events here. When assessing a burn patient, regardless of the location of the burn on the patient's body, the airway should always be a paramount consideration. Ensure that you document all airway findings. As you assess for edema, remember that it is a late sign and you'll need to continuously reevaluate the patient's airway during transport.
I think overall, as an agency, we're doing a great job of identifying stroke alerts and sepsis alerts. I do want to bring attention, though, that there's been some discussion recently about why a saline bolus was not given. These are critical interventions that need to happen on all stroke alerts and all sepsis alerts. In order to capture the ECG data from the monitor during an upload, there must have been at least one snapshot of the 4-lead. After a 4-lead snapshot or 12-lead snapshot has been uploaded, please try to ensure that you list the ECG interpretation in the flowchart. Fire rescue routinely delivers better pre-hospital cardiac arrest management. In order to make that effective, scene time is absolutely imperative to provide the best possible outcome for that patient. Working the patient where they lay when practical should always be the option. A good indicator of when that 20-minute time limit or getting close to that 20-minute time limit has reached its end is the completion of the epinephrine infusion. Let's continue this epinephrine infusion discussion by talking about documentation. Selecting the right epinephrine dosage in the flowchart is absolutely critical. Epinephrine infusion has been created as an option in the flowchart for your entry. Please make sure that you document the concentration and rate as listed below. So the EMS and training division understand that the Zoll X series monitor can be confusing. So I wanted to talk to you guys about the best possible placement and the CPR feedback that the monitor can give you. Zoll recommends the best possible placement for the defibrillation pads is anterior and posterior. I've included a diagram in the middle there. You can see where the pad goes on the anterior side, and the puck has plenty of room to lay on the sternum. However, if the patient is small and it doesn't fit on the right side and it has to go mid-sternum, the puck can be placed on the pad. So let's talk about CPR feedback. A couple things are absolutely necessary in order to make that work effectively. First, and as you can see on the top left, the Zoll adapter, or the gray triangle as we like to call it, has to be on the defibrillation cable, plugged in, and the other side plugged into the CPR defibrillation pads with a puck. Once that's on, as you'll see in the bottom diagram, you'll get a CPR real-time feedback telling you good compression depth, the rate, and it'll give you a metronome. That will be automatically transferred to autopulse and will go away once the autopulse has been put on. The questions has been arising about the filtered ECG, or underlying rhythm. As you can see on the screen, I've highlighted it in blue there. In order to see that filtered ECG, it must be selected on the main screen. If you do not see filtered ECG, you must manually select it and insert it into your line. I'd like to take a minute to recognize the new AED coordinator, Mike Biolay, and congratulate Frank Corriggio on his retirement. Congratulations, Frank. Please make sure you notify Mike of any AED deployment that you may encounter, whether that be a deputy or anyone else. Okay, this concludes this month's EMS action items. I'd like to thank everyone on the quality management team, especially the EMS captains, for their tireless dedication to quality management and review. Please feel free to reach out to the EMS division or your EMS captains for any feedback. Thanks for your time.